All right, thank you everyone for joining today's webinar. We'll give everyone a few more minutes just to log in and get their audio set up.
Hi guys, just wanted to say hi.
Hi, Christy.
Just eating lunch, so I'm going to turn my video off.
All right. Thank you everyone for joining today's presentation. Our presenters for today are Dr. Vivian Mouchouar from the Canadian Research. She's a Canadian Research Chair in Functional Restoration, also the Director of the SMART Network from the University of Alberta. As well, we've got Kelly Larkin Kaiser from the University of Calgary and the Restore Network. And our lived experience for today is Dr. Richdeep Gill. So Alberta SCILS is a monthly webinar series supported by Praxis Spinal Cord Institute and led by health providers from Alberta Health Services and Spinal Cord Injury Alberta, including people with lived experiences. The webinar is co-designed by lived experience experts and clinical experts so that both perspectives are shared during the Alberta SCILS. The webinar is designed for people living with SCIs, their family members, and service providers involved in their lives. We anticipate that the Alberta SCILS will improve audiences' knowledge and empowerment through creating a sense of community, changing perceptions on disability, and improving our social connectedness. And just so that everyone is aware, the Alberta Rehabilitation Advice Line is a telephone advice line supported by HealthLink that provides wayfinder and self-management advice to Albertans with physical conditions relating to an existing musculoskeletal or neurological condition or any post-COVID-19 recovery needs. And the phone number is available on the screen. Just so that everyone is aware, the webinar will be recorded and made publicly accessible. The information contained in these webinars and related materials is not suitable for professional or medical advice, diagnosis, or treatment. If you do have any questions, please contact your medical practitioner for more information to see what is right for you. And some basic housekeeping rules. Everyone will be muted. There will be a short presentation followed by a discussion, and everyone is invited to share their views and opinions. Please feel free to activate your cameras at that point. If you want to participate in the conversation, you can either request to speak in the chat box, wave your hand, or unmute yourself. And we will be monitoring the chat box throughout the presentation. If any questions do arise, feel free to put them in there. And towards the end, you will see some poll questions. If you could please answer those when you see them come up. And I will now hand it over to our first presenter.
Thank you, Alicia. It's great to join everyone for this month's webinar. Now, in my part of the talk, I will provide a general overview of the different modes of spinal cord stimulation currently under investigation for improving function after spinal cord injury, where the primary goal of the stimulation is to reactivate or reawaken spinal networks, allowing them to be more receptive to rehabilitation and improved function. Now, of course, this audience, let me see if I have, oh, there you go. This audience does not need to be reminded that spinal cord injury affects different body regions in different ways, depending on the location of injury and the severity of the injury. And most obvious after spinal cord injury is the loss of mobility. And it seems like I do not have control. I need to go up one slide, Alicia, there we go. Sorry, there may be a little bit of delay, that's why, so I gotta be careful with that. All right, so So I guess the most obvious after spinal cord injury is the loss of mobility, which could affect the legs if the injuries are at the thoracic level or lower, and of course affect both the arms and legs for injuries at the cervical level. Now, spinal cord injury also affects autonomic functions, such as regulation of bladder function. Here again, I'm stuck, heart rate, blood pressure, sweating. Alicia, you may need to just, I'm going to give back control and maybe you just run it for me. I think we have just a lot of people on the line, and that's making everything slow. So let's, I'll just tell you next and we'll go from there. Alicia, you're good?
Sure, unless you want to try it again and I'll just give you control back.
That's okay. How about you go to the next slide? Oh, there we go. Thanks, Alicia. So really what I was trying to say over here is that spinal cord injury also affects autonomic functions such as regulation of bladder function, heart rate, blood pressure, and sweating. And as many would know, most injuries above T6 level result in autonomic dysreflexia. Now, in my part of the talk, I will be focusing on spinal cord stimulation methods that improve walking, while Dr. Kaiser will focus on the control of hemodynamics, particularly blood pressure, and Dr. Gill will describe his personal experience with spinal cord injury. Next, please. Now, there are three different methods of applying electrical stimulation to the spinal cord to activate various networks. And the term neuromodulation is now commonly being used when referring to spinal cord stimulation. And all three methods are still experimental, but they differ in their level of invasiveness and the specificity of what they stimulate. The first method is what you see over here, is non-invasive. It's called transcutaneous spinal cord stimulation, and it's undergoing clinical testing at different centers around the world. Next, please, Alicia. The other two methods of spinal cord stimulation are invasive. One is called epidural spinal cord stimulation, and this is also undergoing clinical testing, mostly in the US and Europe. And next, Alicia, the third method is called intraspinal microstimulation, and that's in the preclinical testing stages. Now, what I'll do today is I'll talk mostly about transcutaneous spinal cord stimulation and then show you the general concepts of epidural spinal cord stimulation and intraspinal microstimulation with a focus on restoring walking. Dr. Kaiser will focus on epidural spinal cord stimulation for improving the regulation of blood pressure. And Dr. Gill will describe his own personal experience with epidural stimulation. And next. Now, to restore walking in conditions of severe spinal cord injury that would be clinically characterized as AGA A or B, we and others have been mostly applying spinal cord stimulation to the lumbar region of the cord. And next. However, we have also recently demonstrated that engaging the spinal networks throughout the cord may be more effective in improving walking capacity. Next. We've in fact run a study where we had participants with AGSC or D spinal cord injury simultaneously cycle with their arms or their legs. We did not use spinal cord stimulation in this study, but we applied electrical stimulation to the legs during the training to assist with the generation of movements. And what we found out is that improvements in walking after training were significant and substantially larger than those possible with current rehabilitation interventions, which mainly exclusively focus on the legs. Next. Now, in these videos, you see an example of the effect of engaging both the arms and the legs, or both the cervical and lumbar regions of the spinal cord simultaneously, and their effect on walking. This study participant had an AGA-C spinal cord injury. Before training, he was hunched over, looking down, walking slowly, and putting a lot of effort in swinging his legs forward. After training, he is standing up straight, no longer needing to look down at his feet during walking, because he has improved sensation that allows him to know where his legs are in space, his spasticity reduced, and he's able to walk much faster relative to pre-training levels. And our goal now is to see how transcutaneous spinal cord stimulation can further improve walking ability when combined with arm and leg cycling as an activity-based therapy. Next, Alicia. So transcutaneous spinal cord stimulation, as I mentioned in the past, is non-invasive, and direct electrodes are placed on the surface of the skin to deliver the electrical current. The stimulating electrodes can be placed over the cervical region of the spinal cord or the lumbar region, as shown here, or other regions along the cord. And then the return electrodes are usually placed around the iliac crest, as you see on the left. Next, Alicia. And maybe you can just hit next until you get to the last line in the slide. Thank you. Now, there have been a number of studies published on the effect of transcutaneous spinal cord stimulation on various functions. For example, there was a study that reported improved upper limb function with cervical transcutaneous spinal cord stimulation, reduced spasticity, movements evoked in the legs with lumbar transcutaneous spinal cord stimulation, improved blood pressure regulation, and one more, Alicia, improved bladder function. Next. However, there is little known about excitability in the nervous system and how it is altered with transcutaneous stimulation across multiple segments of the spinal cord. And that's what we wanted to understand. We want to understand how one location of stimulation would affect other regions of the spinal cord. Next. So we designed a study where we specifically wanted to determine how transcutaneous spinal cord stimulation at one site of the spinal cord would modulate or would affect the activity of networks at other locations within the cord. Next. We wanted to assess the effect of combining cervical and lumbar transcutaneous stimulation simultaneously on the neuromodulation or on affecting the activity within the spinal cord and between the brain and the spinal cord. Next. And we also wanted to evaluate the benefits of combining transcutaneous spinal cord stimulation with arm and leg activity-based therapy. Next. Now, our results, which focused on improving walking, have been a bit surprising. First, we know that engagement of multiple segments in the core during activity-based therapy does produce better results than focusing on the lumbar region only, and I've already shown you that. However, we found that in other words, simultaneously applying transcutaneous spinal cord stimulation to multiple regions is not necessarily better. Interestingly, applying transcutaneous spinal cord stimulation to the cervical region may be best for improving walking. So the study is now open for recruitment, and we are looking for participants with AGA B, C, or D. And if you are interested or want more information, please feel free to contact me or Dr. Trevor Bars in our lab. Now, in the remaining few slides, I would like to quickly touch on the two other methods of spinal cord stimulation. That's epidural spinal cord stimulation and intraspinal microstimulation. Now, for epidural spinal cord stimulation, the stimulating electrodes are surgically implanted over the spinal cord. And what you're looking at over here is a cross-section of the spinal cord. And back is on top, and front is on bottom. And what you see around the spinal cord are the different meningeal layers. The walking networks are in the blue region of the spinal cord. Now, with epidural spinal cord stimulation, just to hit down, Alicia, with epidural spinal cord stimulation, electrodes are implanted on the dorsal surface of the spinal cord, as you could see here in green and black. And when the stimulation is on, it activates the part of the cord shown in red, which then indirectly activates the blue areas, or the areas where walking related networks are. No, you can go to next and just hit down until all the videos are playing. Next and next, yeah, there you go, thank you. So exciting recent work with epidural spinal cord stimulation in people with severe spinal cord injury has been done. And when epidural spinal cord stimulation was used in conjunction with around 1.5 years of physical therapy, people were able to walk nearly 100 meters, as you could see in these videos. And this is quite impressive, given that these individuals were not able to walk at all previously. Now, the last method of spinal cord stimulation, if you could go next, Lisha, is intraspinal microstimulation. And this is something that we are developing in our lab. Our thinking here was that perhaps activation of walking-related networks more directly through very fine electrodes that reach these networks, which you could see in green, may result in even better restoration of walking capacity after severe spinal cord injury. This work, as I mentioned earlier, is in the preclinical stages of testing. Next. Now, we developed a micro implant, which we magnified quite a bit in the picture on the bottom right, and so that you could see it. And this micro implant is placed in the lumbar region of the spinal cord. Next. Or this very small region that you see on the left, and that is circled with the red circle. So if we now blow up that region again to show you what the concept is, the idea is that the electrical stimulus is delivered through very fine wires implanted in the cord, and the stimulus activates the walking networks. And to date, this work has been very successful in preclinical models of spinal cord injury and has led to impressive functional overground walking. Next. And in fact, nearly 1 kilometer of walking was achieved in preclinical models, which is very exciting. And we are now preparing this technology for first-in-human testing. And next. So to conclude, I think a lot of us believe that spinal cord stimulation is likely to be an effective way for improving function, including walking, after spinal cord injury. Next. And the kind of spinal cord stimulation used, whether it's transcutaneous spinal cord stimulation, epidural spinal cord stimulation, or intraspinal microstimulation, depends very much on the injury and on personal goals. So stay tuned for updates on the various studies. Now, I'd like to end by thanking the many different funding agencies that have generously supported our work. And next, the incredible group of people in the lab and our collaborators, both at the University of Alberta and beyond, who make this work possible. Thank you very much.
Thank you so much, and we'll pass over to Kelly.
Okay, I think I have remote access. Oh, thank you for your time, and I'll pass it over to Dr. Gill.
Hey everyone, how's it going? Those are great presentations, and it's wonderful to see the science moving forward, and especially with spinal cord injury, it's been a slow process, right? And so it's great for me to hear about all the work that's being done both in Calgary and in Edmonton, and hopefully around the world as well. I'll give you guys my experience with epidural stimulation and a little bit about my thoughts about it as well. So, after my injury, which was a C5, C6 spinal cord injury, that was Asia A, I did look for a number of clinical trials to see if I may be eligible. And unfortunately, at that time of my injury, these weren't. And it's really great to hear that more of these studies will be made doable and be available nearby. I think the biggest challenge that I found with epidural stimulation and the devices was that the device was initially created for chronic pain, and it's being used off-label for these studies. So it is, it's an interesting device, meaning that to me, it almost seems like this is like the flip phone version of the device rather than the iPhone version, right? Like it is, there's so much potential for it to be enhanced from the software perspective, from the potential of just even being able to provide better coordination of the different signals. But it's interesting to see that hopefully as these studies are done and more research accumulates, that hopefully that will move that part forward. Now, I would say for myself, with my injury being pretty severe, it has not led to me walking or being able to do that on my own. But where I've found it really beneficial has been on two fronts. One, I would say on the rehabilitation side of things. So being able to do more activities when you're at rehab has been really beneficial. So things like assisted stepping and assisted standing has been great. And so it's still challenging, and it's not perfect by any means. And the device does need to be updated or reconfigured and optimized, which it's great to hear that in the study that will be one of the focuses. But it has, at least in my thoughts, helped reduce the risk of complications. So hopefully this is improving like bone density and maintaining some of that muscle mass, and hopefully that will reduce some of the issues we see with contractures and we see with pressure sores. So from the rehab perspective, it's been very, very positive to being able to do those additional exercises and that aspect of it. In terms of the other side, in terms of the autonomic function, for me, the biggest benefit I would definitely say has been in terms of improving my blood pressure. So with my level of injury, especially after I would definitely have episodes of low blood pressure, pretty lightheaded, almost feel like my head is underwater. And that made it difficult to get through the day, difficult to work, difficult to spend time with family. And after spending time with Dr. Phillips' lab and really optimizing the device, and you got to see some pictures of me from the inside during that presentation, which is always funny. It really made a big difference for that. So I'm able to get through the whole day now without having episodes of low blood pressure. I don't take any medications for it. I do run the device on a particular program that's for blood pressure for about an hour a day in the morning. And I have to be honest, I don't know the exact mechanism of why it works well like that, but it seems to cause enough stimulation of my sympathetic nervous system that it doesn't lead to hypotension throughout the day. So I'm able to finish my day at work. I'm able to hang out with the kids in the evening. I get tired at the end of the day just because I'm old, but that's not anything different that probably would have been happening. So that's been a really big positive for me. The program also, the other benefits I found in terms of quality of life, spasticity is a key one as well. So during the day, my spasticity is much better controlled. So I do run the program almost 24 hours a day. The epidural stimulator 24 hours a day at different programs, but throughout the day, usually I run one that's at a very low frequency and a low magnitude, and it is enough to reduce my spasticity throughout the day. One second here. It makes the day go by much easier and less spasticity. Plus, when I run a similar program that reduces spasticity at night, it does let me sleep much better. I find that I'm less restless and I'm able to get a longer duration of sleep. So that's been really helpful in terms of recovering after a long day as well. The other autonomic benefits are always difficult to know, right? I do feel that over time, my challenges with different temperatures have gotten a bit better. It's hard to say if that would have happened without the stimulator or just over time, but I definitely do find that beneficial. Obviously with my injury being pretty high, you always worry about autonomic dysreflexia, but interestingly, and obviously the science of this is not my area, it seems that when I do have like an issue where it would potentially could lead to that, it doesn't cause like a severe headache or makes me feel uncomfortable. Rather, I get a bit of tingling in my head that tells me, okay, it's, I need to either empty my bladder or something like that, but not, but I haven't had any episodes of autonomic dysreflexia since I've had it, which has been, I did have a few episodes when I was in hospital and it was pretty severe. And so fortunately, that has also been an additional benefit of it. In terms of the patients that are interested, individuals that are interested in potentially being part of the clinical trials, I would encourage that. From the surgical perspective of it, it was a very straightforward operation, and for any neurosurgeon will tell you, this is a very straightforward procedure for them to be able to do. The recovery was pretty straightforward. There's not much discomfort, mostly because it's a pretty small incision and how they put the thing together. The most challenging part, I would definitely say, is the optimization or configuring the different programs in which you're trying to optimize. So as the images showed, trying to get it optimized for your blood pressure was an interesting experience, using the tilt tables, and it's interesting. Then when you think about medications, the moment you take a medication, nothing really happens. It takes time for it to kick in. With this device, when you're on a tilt table, you can tell very quickly when they tilt you up that your blood pressure is dropping. Your vision starts to fade a little bit. It starts to feel quite heavy, and then all of a sudden you turn the program on at a particular configuration, and it totally clears. So it's amazing how immediate the effect is. So I would say the overall experience being part of the study, it does take a bit of time, but I would encourage you that it was a pretty positive experience in Dr. Phillips' lab, and all the different colleagues that were wonderful to work with. I think that, so overall, from my perspective, in terms of quality of life, it's been a very positive experience. I think this is definitely a work in progress, and there's a lot of work to be done. But I think the potential, especially for individuals who have potentially a less severe injury, may be able to have additional benefits as well, which hopefully will be seen. And but I think in terms of a technology, there's lots of potential here. This is really, I really do look forward to seeing the true iPhone version of this device and what potential it can have in the future. And the clinical trials of this are the only way to really move things forward. But thank you for your guys' time and allowing me to share my experience as well. And if there's any questions, I'm happy to chat about that, or I'm happy if you contact me and I can tell you more about it, and just individually if that's more comfortable for you. Awesome.
Thank you so much to all of our presenters and our speakers. We will now be moving on to the discussion portion of this webinar. And just so everyone is aware, Dr. Mouchouar does need to leave right at 1 o'clock. So if you have any questions specifically for her, I ask that you ask those first. And I see we've got some questions in the chat box that I think have been answered. So if anyone else has any questions, please feel free to unmute and ask away. So a question just appeared in the chat box.
You got it.
Yeah. So Alicia, can I take this? This is regarding the supports in place to help people from rural areas to access research. So we've done this in the past. Initially, we had support from a special program that at the time the Rick Hansen Institute had initiated, and that was the volunteer or the study participant funding, where the mandate was that it doesn't matter where you are. If you qualify for research in Canada, it doesn't matter where you are in Canada. If you have a spinal cord injury and you qualify for research, you should be supported in being able to get to that research and receive that and be involved in that research. So through that funding, we were actually able to support people coming from everywhere to stay in Canada. So we paid the room and board, we paid the way over, we paid the way back. And at times we paid an in-between in case, obviously, during the duration of the study, people needed to go back and see their families. And that worked tremendously, and that allowed us to work with as many people as possible who really qualified for the study. So that funding that opportunity no longer exists, and I certainly would encourage Praxis to rethink that funding opportunity. But we have incorporated in our funding some mechanism to probably not cover everything, but to help people come over and pay a good chunk of their room and board, but perhaps their travel would be something that they would pay on their own. But we have funds to keep them here if they so choose during the study and the assessments. It's a great question, and the idea is to be able to allow access to research to anyone who qualifies.
Yeah, and I'll just add to that as well. It's really important to us as well that there aren't any barriers to participation, regardless of where you live. So we have, as we've been fundraising for our trial and getting things organized, we've put aside a substantial part of our budget to make sure that we can support people from rural areas and across Canada to participate. So if that's something that you would need, if you were interested in participating, it's certainly something that we can discuss and work out so that that isn't an issue.
There's a question regarding my contact information, so I'm going to put that in. I'm going to put my email in the chat, and that would be the easiest way to contact me. But I can also put my office number. And yeah, please feel free to reach out if you'd like to.
And I see that, Beto, you have a question?
Can you hear me? Yep. Hi, so thank you very much, Vivian, Kelly, and Rich. This has been a very enjoyable presentation for me as a clinician and also as a researcher. I want to take one of the elements of Guy's question about when could this be available for all Albertans? And I think it's a good question for the three of you, because this is a question for me about how quickly can we accelerate the positive findings of such technology so we can benefit the population here, just taking into consideration that we know that valley of the dead, right, concept of all the research that happens, and not more than 20% really gets to real life. By real life, I mean that it's common practice for people in a province, for example, in our concept. So what do you guys think about this? And what should be the steps that we could take as a province so we can make sure that this happens and that this important research does not perish in the valley of the dead, right?
You guys mind if I give my opinion first? Sorry, I'm watching the time here because I have to run off. But your question, Beto, thank you very much for asking that, is in line with the question that Brenda Schultz had put in the chat for everyone. In other words, where are we and how do we get there? So obviously the process of getting a medical device accepted is quite rigorous. And for devices that are non-invasive, they can go into clinical practice sooner than the devices that are invasive. But there are also devices that are invasive, like epidural stimulation. It's been around for a long time. It's been around for 60, 70 years. Okay, and it's been used for pain. It started off in the 60s. And it's it's commonly used to treat intractable pain. So you would say this device is already available. Why isn't it? Why can it not be used for spinal cord injury and all the benefits that have been discussed? Well, the reason for that is because it's not the indication that it was approved for, right? So it was approved for pain. It was not approved for autonomic dysreflexia. It was not approved for standing, walking. So that's the reason for that. And the way to get it is to get these devices there. For example, for transcutaneous, we already have applied, and many across Canada have applied for investigational testing authorization so that we can increase the number of studies in Canada, and collectively, hopefully, we'll be able to provide enough evidence to Health Canada to say, okay, this should be approved as a medical device for persons with a spinal cord injury. The next step would be, of course, for Alberta Health Services and other health authorities to accept that. For epidural stimulation, there's again a lot of evidence that this invasive approach is acceptable, right, and beneficial, but it's not clear yet. There's a lot of nice studies, really beautiful studies that demonstrate benefits, but they're all kind of referred to as small studies, sometimes anecdotal, which we need to be able to get over, right? So in other words, a study like Dr. Kaiser has described, where you have a systematic, rigorous a study where it's not just one or two people, it's really statistically driven study that would prove and would provide definitive evidence, then those results can go to Health Canada, and after review, probably it will be approved for the indication. So if the study is for monitoring blood pressure or for improving blood pressure, that's what it would be approved for. That's the one challenge, right? You have to get a device approved. Even though it's the same device, it needs to be approved for every single indication. For intraspinal microstimulation, well, we're still in the preclinical stages. So there's still a bit of ways to go, although it's much shorter than it was in the past. So we're expecting to go to Health Canada within about 3 years or so, and then we'll go from there and see what they need to get the device approved for testing, not approved for use. So it's a process. It's not that Canada doesn't want to do this. It's not that Alberta doesn't want to do this. Epidural stimulation is not approved anywhere in the Western world for conditions related to spinal cord injury, right? So it's not that Canada is not doing what should be doing, but certainly we do need to increase the number of studies, and we are behind in the number of studies for epidural stimulation. That's definitely the case. So hang in there. Studies like Dr. Kaiser's are going to get us there, and it's just a process. And the idea is protection of the persons, regardless of what their indication, and not allowing rampant use of devices in such a way that would hurt people. That's really the idea.
I think just to add to that too, these trials that we have coming up are really going to make a case for Medtronic to also be willing to go to Health Canada to request indication, which getting their buy-in is also something that's really important. So that's something that we're certainly pursuing. And then the development of the novel devices from scratch, for a lack of a better word, the iPhone version, as Richie mentioned, that are kind of happening in the background, those are going to have to still go through the full Health Canada approval pipeline. And we have had multiple conversations with Health Canada already. They're very excited about the potential. They're very supportive of the trials and of making sure that this therapy is available to Canadians. We just still have to jump through all those logistical hoops, right? Which is always the challenge, and it's slower than people want it to be, of course, and it can be somewhat frustrating. But I think that in Canada, there's a lot of researchers that are very dedicated to this, and it's certainly starting to show a lot of promise. I don't really have much concern of the research going to the Valley of Death. I think that people are incredibly committed and really just devoted to making this happen for Canadians. So we're on our way.
Thank you so much for that. Before we move on to the next question, can I ask Joanna to throw up the poll questions just before people start logging off on their lunch breaks here? So you'll notice on your screen, some poll questions will come up. If you can go ahead and answer those while we move on to our next question. There was one in the chat box. So there's a question here that says, I'm an Asia A T8, T4 paraplegic, and I'm in the intake process for the E-Stand trial in Minnesota. How does that compare to some of the trials going on here in Alberta?
So for us, for standing, for standing and walking, we are primarily taking Asia B, C, and D at this point. At least that's the funding that we have approved. That doesn't mean that AGA would not be included in the future, but that's for the transcutaneous stimulation. The intraspinal stimulation is all AGA primarily. So that we would, once we get there, we'd be flipping the equation and focusing on AGA primarily, with probably some AGA B as well. But for transcutaneous, it's B, C, and D right now.
And for epidural, I think the ESTAN trial, the major difference between what they're doing in Minnesota and what we're trying to do here is Minnesota is slightly more focused on the motor function recovery, whereas we're more focused on the autonomic control. So the patient populations are slightly different, and the eligible patient populations are slightly different, and the location of the implant will be slightly different because of the targeted results. So those are the differences, but we do work in really close collaboration with the ESTAN team. Dr. Phillips has been working with them for years. So if you want more information about the similarities and differences, please just reach out and let us know.
So we do have another question in the chat box, and then we do have a participant who has their hand up. So we'll do the one in the chat box first, and then we'll head over to Francie for her question. So the question is there any external electrical stimulation in Calgary, or is it only in Edmonton? And I think
Yeah, I can see Dr. Mouchouar has answered that they have 3 transcutaneous spinal cord stimulators in Edmonton. We're not currently doing any external stimulation trials at the moment, but we might be in the future. Just have to wait and see how things go.
Thank you. And then I think it's Francie has their hand up with a question. You can go ahead and unmute.
Thanks. Hi. I have a couple questions. My first one is, I use a Medtronic insulin pump already. And this device, it's attached to your body and you like clip it on your waistband. Will that be a similar sort of device? I'm not sure if you're familiar with the Medtronic insulin pump, but would that be similar? Do you have any pictures or anything what that looks like? That would be my first.
Yeah, so the epidural stimulator, the lead is of course implanted over the epidural space, and then the IPG is actually implanted subcutaneously over the upper buttock. So they're both indwelling, and then there's a patient controller and a physician controller on a tablet where you can modulate the setting. So it's slightly different than the indwelling insulin pump.
So it's not actually,
from what I understand.
Sorry, so it's not actually connected through like a wire, or because the insulin pumps have like a cannula that goes between the actual device that you would hold.
Yeah,
I see.
So yeah, there are wires from the lead to the IPG, but they're all implanted internally.
Okay, cool. And then my other question is, I've been on different trials before in the past, and at the end of them, I've liked some of the products, but there hasn't been support to be able to stay on them. And I wonder if somebody who gets used to being on like a device like this, especially if it's helping to improve your blood pressure, you fall in love with the product, but we're waiting for approvals. It could be a number of years. So I'm just wondering, what kind of supports will you have in place? Do you have any plans to support patients that would want to stay on the product while they're waiting for approval from Health Canada?
Yeah, you know, Francie, this has been the age-old question. And it's a question that we researchers struggle with tremendously. Because we get the funding from different agencies to perform the study, and then but hardly anyone gives you funding to maintain the devices and continue to work with them moving forward. So so this is driven some universities and some researchers. An example of that is Case Western Reserve University, where they said, look, this is not ethically acceptable. We have to now start putting funding aside to support all our study participants who receive implants, who are, whose studies are no longer funded because the funding has run out. And it's something that we're thinking about as well moving forward, so that we are able to either fundraise or incorporate specifically in a grant some sort of funding that would allow for prolonged support of the devices after the study is finished. But one thing to keep in mind is that each study has a deadline and has to have a deadline. That's what Health Canada wants you to do. But often for implants, people are given the option. Do you want us to remain so basically you'd say, technically the study is done, we should remove the implant, but would you like us to leave the implant? And so you give the study participant that option of whether they want to keep the implant in or not. And often study participants do want the implant to stay unless it's just not working for them. So these are the people who we need to keep in mind and figure out how we can continue to support them, even though the study has finished. And I think it's very important for everyone to keep in mind that when you go to Health Canada, especially if it's an implant, do keep that in mind, that you don't want Health Canada to say, no, the implant has to come out after a certain period of time. It's important to keep in mind and in the protocol to say that the study participant will choose whether they want the implant taken out or not. I think that's very important. It's something that a pitfall not to fall in. Then the most important thing becomes how do you fund the continued support of the study participants until the systems become available in the future. And much to my dismay, I have to run off. Sorry, guys, that I spoke too much, but I have to run off to an interview that started 2 minutes ago. So thank you, everyone, and please feel free to get hold of me if you have any questions. See you guys. Thanks, Alicia.
Thank you so much. Do we have any other questions?
I was just going to add one thing to in terms of the device. So it does actually last for quite a while, and hopefully with the rechargeable batteries, like it can almost last 8 or 9 years. So fingers crossed. Hopefully by then they'll have this approved, and you would have competition enough between the different groups that the device would be improved in terms of technology. Right? Because at the end of the day, that's the only thing that leads to the technology being better, is that there's a market for it and that different companies are able to compete for it that way. So, and if you do have the device, typically like Medtronic, and I won't speak for them, but they will help with the maintenance part of it. Because they're still responsible for the device if it's in you in that sense too. So not totally on your own, but it's not as well defined for sure as it could be. And hopefully that will get better as these studies are moving forward.
Yeah, for our trial in Calgary, we do have the option of, we have 3 options when people complete the trial. It's either to have the device explanted, to leave it implanted, but to deactivate it, or to keep it on and continue to use it. But we are also currently trying to find additional funding so that we can do a long-term follow-up study after the clinical trial has ended, so that we can continue to provide that configuration support, especially because over time, the device does need to be tuned and re-optimized for the settings. So looking for funding for that, those are harder trials to fund than the big splashy ones. So I think a lot of advocacy and fundraising within the community is also going to be really important.
Thank you so much for those. Do we have any other questions from any of the participants? No, it doesn't look like it. So just wanted to let everyone know, if you do have any more questions, please feel free to join us in our post-webinar chat that our peer coordinators will be hosting, which will be next Monday at the exact same time. And the info for the Zoom ID is on the screen. Also, you can find all of our information for upcoming webinars, as well as post-webinar chats on any of Spinal Cord Injury Alberta's social media platforms. As well, if you have any additional questions, please reach out to Terry. His email is at the bottom. So again, thank you so much to all of our presenters and speakers, and thank you everyone so much for joining our webinar. And we hope to see you next Monday in our post-webinar chat.
Thanks, guys. That was a great presentation.